Our next speaker will keep our questions until the end of the session. Our next speaker is none other than Dr. Murewanhema. He's a local fellow, but also a PhD fellow with AWACAN-ED, and has a special interest in artificial intelligence regarding assessment of sexual and reproductive health interventions. Let's give a round of applause for Dr. Murewanhema.
Thank you, Dr. Bipa. Good morning once again, colleagues. I'm going to make this very short because Dr. Matonzi has set the pace for this, and I'm just introducing a study that we are conducting locally, whose results will become available in the second quarter of 2024. Sincere gratitude to Uncle Mike, who's here, who is my mentor and has been sort of teaching me to do this research. I really appreciate him for that. So I think most of this stuff has been said. I do not really want to go with this. We know that cervical cancer is the most frequent cause of cancer deaths among females in our country. And it's almost overtaking all cancers, and this is data that's available from the Zimbabwe National Cancer Registry. And like Dr. Matonzi just highlighted, primary prevention through vaccination with efficacious vaccines is probably the future of HPV prevention, alongside screening with high-performance HPV DNA testing. So again, I do not want to bore you with this. These are available from the Global Health website. You can look at them, but they're just showing us that cervical cancer is really a disease of public health significance in our country. And I think this is basically just showing the same information as well, representing the age standardized incidence rate as well as the estimated relative mortality from cervical cancer compared to other cancers. And the WHO does really emphasize a life course approach to prevention of cervical cancer, where we look at the 3 tiers, or from an epidemiological point of view, we look at 4 tiers of prevention. The first tier, which is primordial prevention, is something that people rarely talk about. But if you look at results that were published from a trial that was done by one of the groups working in Zimbabwe through the London School of Hygiene and Tropical Medicine, I think primordial prevention was really important because the incidence and prevalence of sexually transmitted infections among adolescents in our population is much, much higher than what we expected, meaning that these young people are actually indulging quite early, and we should emphasize behavior change as part of primordial prevention. And then obviously primary prevention through vaccination is really critical. So in Zimbabwe, we know that secondary prevention is the mainstay of cervical cancer prevention, and the modalities that we have include visual inspection under acetic acid, as well as cytology, whose uptake has not been so great, or whose utility has not been so great because of various factors. In Zimbabwe is the National Cervical Cancer Prevention Task Force. We have written up guidelines to say we need to move to HPV DNA screening as the primary screening modality for cervical cancer. We are waiting for the higher authorities to approve that document, and then we should probably be moving to that. And it will be a screen triagent approach with either VR or colposcopy as the triaging modalities after testing with HPV vaccine. And then obviously would be encouraging, particularly in the peripheries, the adoption of thermal ablation as the primary treatment modality for cervical cancer. And of course, we are also doing studies that are looking at artificial intelligence for cervical cancer screening. We just completed an automated visual evaluation study where we recruited about 12,000 participants across different countries in Africa. And this was sponsored by the Clinton Health Access Initiative. Dr. Guja and myself were also involved in this study. And I think Dr. Guja will also probably be conducting an IAC-sponsored study again looking at automated visual inspection in the near future. So what about HPV vaccination? This has really been talked about by Dr. Matonzi in detail. We are talking about prophylactic vaccines here because there is also the other arm of vaccines that are undergoing evaluation. Those are the therapeutic vaccines. And really, in terms of the WHO's global strategy for the elimination of cervical cancer as a disease of public health concern, the aim is to have 90% of girls aged 9 to 14 years to be vaccinated by an efficacious HPV vaccine. And we do have 6 approved HPV vaccines on the global market. 4 of them are bivalent vaccines, 2 are quadrivalent vaccines, and of course we have the Gardasil-9, which is a monovalent vaccine. The International Agency for Research on Cancer about 2 months ago released their brief and made the presentation at the International Papillomavirus Conference, where they showed that 1 dose of a bivalent HPV vaccine is probably good enough for our population in terms of prevention of cervical cancer. And 1 dose, this is really discussed at high levels now to try and push towards 1 dose vaccination. The idea is that this will improve accessibility, vaccine supply, and acceptability, but it also widely increase vaccination coverage. So just for the registrars and others, this is a summary of the 6 vaccines that are available in the global market. So it's not just several, it's Gardasil-9, but indeed there are 3 other ones that are administered. So what about the HPV vaccination program in Zimbabwe? We know we are running the national school-based vaccination program with the bivalent HPV vaccine. This follows a pilot that was done in Murewanhema in State region 2014 to 2015, which really had a great coverage, in excess of 80%. And so Zimbabwe has initiated a nationwide school-based HPV vaccination program similar to other countries. And apart from the interruption that was caused by the COVID-19 pandemic, this program has really been achieving good coverage rates. And this we've already talked about 2 doses targeting girls aged 14 years to 1 month apart. The problem is we mainly know the effectiveness of HPV vaccines from studies done elsewhere, particularly in the setting of randomized controlled clinical trials, but we have not done many studies in our local population to assess the long-term effectiveness of HPV vaccines. So why is it important to assess the effectiveness of HPV vaccines? It's important because it will help us to predict the future burden of cervical cancer. It will also help us to inform our screening and cervical cancer control policies at a policy level, and to help to project the expected impact of HPV vaccination. So we know that the assessment of the effectiveness or the impact of vaccination on cervical cancer is really complicated by the long time from initial infection with high-risk HPV vaccine, HPV genotype to carcinogenesis, which you look at, if you look at the natural history, this can be over several decades. And so we need ways of using these proxies to assess the effectiveness of vaccine programs. So in the current study that I summarized here, we are assessing the current type-specific prevalence of HPV vaccine, HPV infection in Harare and Chitunguiza among women aged 19 to 23 years, measuring HPV DNA prevalence in vaccinated death cohorts, and we're using this as a baseline. which will then be followed up 5 years later by a similar survey, but this time also consisting mainly of a vaccinated population. So that's kind of the conceptual framework that we are using for these studies. They have been conducted in other settings in Rwanda, Bhutan, and Armenia. So Zimbabwe is the 4th country to conduct such a study. So at the moment, we are saying the population that we're mainly dealing with consists of unvaccinated young women and adolescent girls, but there could be some who have been vaccinated either from the pilot program or also from the private sector, but the majority of those that we'll be dealing with are unvaccinated. Come 5 years later, 5 years later, the majority of girls in that age group will now be vaccinated with an HPV vaccination, but still in that population, there will still be some girls who are unvaccinated. So this is kind of the concept that we'll then use to try and determine the indirect effectiveness of the HPV vaccines and their overall effectiveness over time. So we'll survey. So this next diagram really just represents the concept that we're looking at these girls who were vaccinated at this point, and where are we going to be in the next 10 years or so in terms of age. So it's basically a population-based cross-sectional survey. We are conducting this at 4 clinical research sites, 2 of them in Harare and 2 of them in Chitribiza. We are aiming to recruit approximately 2,540 women, of which to date we have recruited about 2,496 of these women. We got the number of the sample size of 2,540 based on previous studies that we conducted in other settings. And so we collect urine samples from the participants, and we also administer a questionnaire on them that we capture via RedCap, asking them a set of social demographic questions, sexual related behavior, and so on as risk factors for cervical cancer as well. At the moment, the testing of the specimens will be done in the Netherlands, so we periodically ship these specimens to the Netherlands for testing. So this is just showing the numbers. Like I said, to date we've recruited 2,498 out of the 2,540 expected participants, and I expect that we will complete recruitment by the end of this month. So our experience so far, before we have the results from the analysis, what we're noting is that self-collection of urine specimens is really acceptable among women, and this also goes with self-collection of vaginal swabs for HPV DNA testing, which we are also trying to widely campaign for. So this is really acceptable, and our population is willing to take part in studies that are related to cervical cancer prevention, which is something that we should take advantage of. And the healthcare workers that we are working with also find urine-based surveys as an easy and acceptable method of collection compared to other studies. So, and then, like I said, the next steps is we are completing approval that at the end of this month, and then we'll start analysis once the samples have been, the biological samples have been analyzed in the Netherlands. But when it comes to such studies where testing is happening elsewhere, we are always worried about sustainability once the study goes. So we are now working with international partners for validation of urine assays, and hopefully if we can find this working, we can then bring this to Zimbabwe as one of the ways of collecting samples. And we will also be repeating a similar survey in the HIV positive population. And like I said, this is a baseline survey, so we're going to have another survey 5 years later. And so just a word of acknowledgement to the people we work with. These are some of the clinical research sites that we work with. You can see Uncle Mike here, and my other co-mentor, Dr. Phillips, who's not here. and the staff that we work with in the clinical research sites. And my special thanks to the University of Zimbabwe Clinical Trial Research Center and the International Agency for Research on Cancer, who are the funders of this study. Thank you.